Clinical Communication Criterion, C5, is the final obstacle standing between international medical graduates and their passing grade. Most candidates assume that C5 is simply a test of medical accuracy. They believe that if they deliver every treatment detail printed on their candidate card, they will automatically secure maximum marks. That is a critical error. In the OET Speaking assessment, examiners are not grading how much medical data leaves your mouth. They are grading how effectively that information is structured, chunked, and verified by the patient under time pressure. When candidates cross the 3-minute threshold and realize the clock is expiring, psychological panic triggers. They open their mouths and execute what we call an information dump, broadcasting a continuous wall of dense clinical facts without stopping for air. When a patient is in a medical crisis, their working memory ceiling drops significantly. If you lecture them, retention drops to 0, compliance vanishes, and your structure score collapses. In this video of our criteria series, I will decode the 2 fatal information-giving hazards and project the exact masterclass mechanics required to execute chunking, open verification nodes, and the forward sweep. The most frequent C5 failure occurs when candidates realize they have less than 2 minutes remaining before the final buzzer. To clear every medical task on their card, they accelerate their speech velocity and stream multi-tier medical instructions in a single unbroken sequence. Observe the live acoustic intercept on your screen as a candidate suffers a complete stage 3 structural hemorrhage.
Okay, Mr. Miller, so since your blood sugar is highly elevated, you need to begin this insulin protocol immediately, which means injecting twice a day before meals, and you must rotate the injection sites to avoid tissue damage. And you also need to carry fast-acting glucose tablets in case you experience sudden hypoglycemia. And I need you to completely re-engineer your carbohydrate intake and book an appointment with our clinic nurse for Monday morning. Does everything make sense to you?
Analyze that execution. That is a fatal communication liability. The candidate broadcast 6 separate complex clinical concepts at an anxious patient without a single breath or pause. Under exam pressure, you might feel like you are checking off tasks, but on the assessor's scorecard, your structure score is completely collapsing. The patient cannot process multi-tiered operational data streams. If you lecture them, you fail the consultation. To secure a passing grade under criterion C5, you must replace spontaneous lecturing with a mechanical framework known as chunking and checking. Chunking is the deliberate clinical process of slicing complex medical instructions into completely isolated single concept data units. An engineered chunk contains exactly 1 piece of medical information, immediately bounded by a clear drop in your vocal pitch and a mandatory 2-second structural pause. You do not explain medication protocols, lifestyle adjustments, and follow-up requirements in a single breath. You isolate them completely. Analyze the architectural mechanics of this masterclass correction.
Mr. Miller, managing this blood glucose involves 3 separate steps. First, we need to initiate a daily insulin protocol to stabilize your levels. Second, we will look at adjusting your daily carbohydrate intake. And finally, we will schedule a review with our clinic nurse for Monday morning.
Look at the mechanics of that phrase. By using explicit sequential signposts, first, second, and finally, you remove all unpredictability. You provide the patient's brain with pre-constructed filing slots. They know exactly where the conversation is going, which automatically stops them from interrupting you with premature questions, locking in absolute command over the room's momentum. The second major C5 failure occurs at the end of an information block, when candidates attempt to check patient understanding using closed verification loops. Candidates routinely default to weak closed checks, such as, "Do you understand? Is that clear?" or "Does that make sense?" Listen to why this fails.
So you need to take these tablets twice daily after meals. Do you understand?
In a testing environment, An anxious patient will reflexively nod and say yes simply to escape cognitive pressure, even if they are entirely confused. Assessors spot this instantly and penalize it as a passive compliance check. You have checked if the patient heard your voice. You have not checked if the patient can integrate the medicine into their reality. To secure maximum relationship and information giving marks, your verification mechanism must be open, collaborative, and conversational. You must deploy open verification nodes that force active patient participation. Analyze the pacing and structure of this masterclass correction.
Mr. Miller, we've covered our first step regarding your insulin schedule. How manageable does that routine sound to you?
Look at what was accomplished. You are not asking if he understands the medical theory. You are asking if he can execute the task in his daily life. Because you asked an open question, the patient is forced to participate, revealing any hidden operational resistance so you can resolve it safely. Once you have verified your chunks, you land the consultation cleanly before the final 5-minute buzzer using the forward sweep. Look at the final 30-second sweep on your display.
To summarize our immediate next steps today, we are going to start your new medication tomorrow morning and we will adjust your diet step by step. Now, if you experience any severe dizziness or sudden fever over the weekend, I need you to bypass our clinic and go straight to the emergency department. I will see you back here next Thursday. Take care.
Look at that final architecture. You executed a forward sweep, mapping immediate physical steps. You set a rigid conditional safety net for emergencies, and you dropped the final anchor. I will see you back here next Thursday. Take care. The final anchor tells the interlocutor and the assessor that the consultation is officially complete. You did not run out of time, and you were not cut off mid-sentence. You controlled the clock systematically from the first breath to the final buzzer. You now possess the complete structural blueprint across all 5 clinical communication criteria. You know how to validate patients in C1, handle resistance in C2, command the clock in C3, extract targeted data in C4, and chunk your information cleanly in C5. Delivering a passing OET consultation is not about guessing vocabulary or improvising under pressure. It is about committing these exact structural frameworks directly into physical muscle memory. Do not leave your GMC registration to chance. Click the link in the description below to run my free timeline integrity audit. This interactive diagnostic tool will evaluate your consultation mechanics, calculate your exact risk of a structural collapse, and show you precisely how to lock in your 350 plus pass before test day. Run the audit, master the blueprint, and I will see you inside the masterclass. Go and execute.